We are on a mission.
A mission to save and revitalize independent pharmacy.
On the Catalyst Pharmacy podcast,
you will get actionable business advice,
hear stories from industry leaders,
and share a laugh with us.
Fuel your passion for pharmacy,
one conversation at a time.
Hey Scott, how are you?
Hey, I'm well.
I'm digging the Auburn quarter zip and the hat. I love this look. I love it.
Yeah. Well, the hat's APC. I told him I tend to wear a ball cap all the time, so I'll take it off if you want me to. But,
no, not at all. Not at all.
There is no hair under the cap. So
look at me.
Yeah. Yeah.
I have the inklings of what could be hair, and it's gone. My kids have it now, for the most part. So I wanted to quickly introduce Scott Brunner. And Scott, tell me what I have wrong here, but we wrote you a little bit of an intro here. Currently the CEO at Alliance for Pharmacy Compounding, APC, I think what some people will know it as. Former Senior Vice President of Communications and State Government Affairs at NCPA. So a lot of people on this podcast that watch this, that listen to this, probably already know you. And also former CEO for Georgia Pharmacy Association in the pharmacy world. So been running with legislative affairs, government affairs, running trade associations for many years in pharmacy, and a pharmacy advocate.
Yeah, and all that's correct. I cut my teeth in pharmacy with the Georgia Pharmacy Association. Still love those folks. Learned a lot at NCPA, and then was stolen away about 5 years ago by, at the time, we were IACP, the International Academy of Compounding Pharmacists. Okay. And, a year or so later, we broadened our scope, changed our name, but we are the organization, we're the trade association for pharmacy compounding.
Yeah, so I'll say this. So let's talk about that a little bit. Like what APC or Alliance for Pharmacy Compounding stands for today. I was reading through the website and stuff like that. Not every pharmacist that listens to this is a compounder in itself either. So if you could you give us just a little background on like APC, what it's kind of doing today? I know last year you said we kind of talked a little bit, and you said you were kind of really kind of knees deep into I'll just say some of the brand names of GLP-1s and things like that. But like what else broader that APC does as a trade association? Well,
we're the advocacy organization for pharmacy compounding. And our membership really spans the scope of the profession, certainly compounding pharmacists, compounding pharmacy owners, technicians, but also vendors in the space, marketers, educators. We even have some prescribers who are members of the organization. And the thing we do is work to protect patient access to compounded medications. Sure. We recognize that FDA-approved drugs, and I'll refer to them as FDA-approved or manufactured or commercially available drugs, are always the standard, and they are the go-to. But there are many instances when an FDA-approved drug doesn't come in a dosage form or dosage strength for a particular patient, and that's when compounding is absolutely appropriate and is authorized in federal law. The Food, Drug, and Cosmetic Act carves out a place for compounding because Congress recognizes, frankly, I would say that the American healthcare system would grind to a halt without compounding, particularly when you consider all the compounded medications that are used in hospitals, et cetera. And yet, and we'll talk a little bit more about this, the profession continues to be characterized in media as somehow marginal or even sketchy. I would suggest to you that FDA has contributed to that in many ways, and it's not fair. But we've got folks doing really valuable work in helping people live normal lives.
Yeah, one thing I would say too, if that probably is some of the narrative for some people, maybe. I don't think people realize how regulated it is, if anything. Right?
Oh yeah, it is a highly regulated profession. Start with USP, the U.S. Pharmacopoeia, promulgate standards for sterile and non-sterile compounding, for hazardous drug compounding, et cetera. And almost every state law incorporates those USP standards into law or reg. And so on any given day, a pharmacy could be inspected by its state board of pharmacy. It could be inspected by FDA, by DEA. The equipment that they use must come. It must be inspected. The API, the active pharmaceutical ingredient, must come from FDA registered facilities. So there are many highly regulated industries, but I would say compounding is right up there, and rightly so. I mean, we stand for a strong regulatory framework, but it needs to be a framework that doesn't inhibit the ability of people to get compounded meds when they need them.
Okay, yeah, that makes sense. So let's talk a little bit about, like, since that is what APC does, and so let's talk through a little bit about, like, kind of year in review since it's a new year, it's a new us. I've got a New Year's resolution. I don't know about you. My evergreen New Year's resolution is to lose 20 pounds every year. I'm closer this year than I've ever been, but
good work. Well, hey, maybe you need a GLP-1. Those seem to be the topic du jour.
Yeah. Right. So let's talk through a little bit of that. That's a good segue. About how is what did APC have to kind of wrangle a little bit from a fires perspective, but also strategically maybe in 2023 were you able to get done or tee up?
Yeah, shortage drug compounding and the downstream effects of shortage drug compounding have really occupied all the airspace for APC over the past year. We've got several legislative proposals pending before Congress, and I'd love to share about those. But right now, I mean, I could pick up back 6 months, 9 months ago, between March and probably August, on any given phone call, I could answer it and say semaglutide hotline, that would have been the right answer. I would have, in many instances, a reporter from major media outlets doing the story about GLP-1s, particularly, and I pronounce it both ways, semaglutide.
I'm not even trying it.
Wanting information about that. And there's great misunderstanding in the space. And as I've said, I think FDA has sort of fed that misperception.
Okay.
So when it comes to shortage drug compounding, let's just give it a little lesson, because I do these presentations even to pharmacists, and I find that many pharmacists don't necessarily know what can be compounded and what cannot. So under federal law, in order to be compounded, a substance has to either be a component of an FDA-approved drug. Okay. Semaglutide certainly is. Wegovy and Ozempic. It must, or it must have a USP or National Formulary monograph, or it needs to be on FDA's bulks list. And if it doesn't meet one of those criteria, then you shouldn't be compounding it. At the same time, FDA provides guidance on, we call it essentially a copy. Compounders are forbidden in federal law from compounding essentially a copy of an FDA-approved drug.
Okay.
Except when that drug is on the FDA drug shortage list.
I got you.
And so with some of the recurring drug shortages in COVID and after COVID, Congress is certainly working on providing better ways to get some of these short cancer drugs, cisplatin and others. And there's a place for compounders to be helpful in that. We need to be authorized to do that. But there's a framework in place for 503B outsourcing facilities to be able to prepare copies of FDA-approved drugs when the drug appears on the shortage list.
Okay.
But there's typically, drug goes on shortage.
Sure.
Immediately, that 503B is not going to be able to ramp up tomorrow and prepare that drug. They have to meet the CGMP requirements. It takes time, 3 to 9 months in some instances.
And can I clarify one thing on a 503B? I know we're using acronyms for everybody here, but what I understand that to be, and you tell me if I'm wrong. Usually it's going to be a pharmacy really built out for, I will just say, manufacturing these compounds in for distribution, really.
Correct.
Right.
Correct.
And so different than a 503A. A 503A is going to typically be your independent pharmacy or your community pharmacy that is usually only compounding this and pursuant to, sorry, I don't mean to use legal jargon here. I read it off your website though.
Right. Yeah.
Pursuant to a prescription, right? You have a prescription, you're gonna fill it. So I just wanted to like clarify that for like the audience and some of that too. We have a lot of people that watch it. They're just different.
Well, and the interesting thing about the 503Bs, they were created in 2013 with DQSA.
Right.
They distribute, as you said, and that basically means they can provide large quantities of compounded drugs without a prescription.
Right.
So, as I indicated earlier, hospitals rely on 503Bs. Many of them to provide a lot of the drugs they need
do.
For surgery.
Every health system pharmacy I've been into is using a 503B facility in some way.
Yeah, absolutely.
Yep.
503As dispense. And so that's there are two D words there. 503Bs distribute,
right,
means no prescription. 503As dispense, which means it's always pursuant to a prescription. And so 503Bs, if they can ramp up to meet drug shortages, that's great. And they've done this over the past year, and it's just marvelous. But it takes time. So what happens in that interim period when the 503B is having to ramp up and the drug's in shortage?
You want your 503A to be nimble and do it, right? Am I barking up the right tree?
Exactly. Part of the problem is, though, okay, you've got this gap and you've got hospitals that need certain drugs, and yet 503As can only dispense pursuant to a prescription. Mm-hmm. And so what we've asked FDA to do, and we've worked on over the past year with Congress, is to create an avenue for 503As to distribute when a drug is in shortage and the hospital or healthcare, the clinic cannot source the drug from the manufacturer or from a 503B. And we would suggest that be done in very tight guardrails. And it's an exception to the rule, and it is temporary. But if we had that guidance, we could certainly help hospitals source drugs that they need, as was allowed under temporary guidance during COVID. FDA approved 503As to do that for 13 COVID drugs, and there was not a single adverse event reported. So we'd like to make that permanent.
And to me, it makes a lot of sense, especially when you're talking about like rural. Especially, I always go back to like rural and pharmacy deserts and critical access hospitals and things like that. You know, think about the folks that it's a good bit of ways. It's quite a few miles away in between them and whatever it is, whatever that 503B facility is, plus the ramp up time. Why couldn't you just tap into your local community with someone that's really nimble, skilled in doing it, maybe even accredited? I don't know if that has to be a thing or not. Or at least from a state board level, usually indicated of what they're doing. I know a couple of states are making a little more headway in, I think, enumerating, I'll just say, pharmacies and what their capabilities are from a pharmacy perspective, from a compounding perspective. But yeah, it just seems like it totally makes perfect sense to be able, even if it's just temporarily, tap into your local community in order to serve patients on really something that most of the time, like a lot of the time, it's not just GLP-1s, it's these other things that are fairly generic or you would think widely available. They're just not.
Think about over the past year and a half, really. Think about the shortage of acetaminophen suspension, ibuprofen suspension.
Right.
And unfortunately, they were never on the FDA drug shortage list. Yeah, they were on the ASHP drug shortage list, which is a much more real-time indicator of shortages. We would love to see and have proposed. In fact, earlier this week, we proposed to FDA some enhancements to the FDA drug shortage list so that it would be more real time, so that it would get input from more than the manufacturers, but also from physicians and hospitals and that sort of thing. We'll see where that goes. But all that is to lead us to GLP-1s, which in the media at least have shown a light on pharmacy compounding in a way that we've not seen in a long time. So as I said earlier, federal law makes an exception for compounding essentially a copy of an FDA-approved drug when the drug appears on the shortage list. Semaglutide has appeared on the FDA drug shortage list since March of 2022, We're going on 2 years now. And so, because it meets the requirement of what can be compounded, semaglutide is a component of an FDA-approved drug, prescribers have begun to write for a compounded
version of that.
Yep. Yeah. And same thing with tirzepatide. Tirzepatide, that's the Eli Lilly product. It's Mounjaro is the commercially available product, and tirzepatide's the active pharmaceutical ingredient. And it has not been on the list as long, but it is currently on the list. And so both are being compounded. One of the misperceptions that I see in the media is that for some reason media seem to refer to compounded medications as things like counterfeits. That's just not true. As generics, compounded medications are not generic drugs. They have not gone through the new drug approval process. Right. They've not done any of that. They are not knockoffs. They are they're not potions or concoctions. And I've seen all of that in news reports about compounded semaglutide over the past year or so. Another thing that the media doesn't seem to realize is that compounders can't just up and decide to dispense a compounded medication. There is a prescriber in whose judgment that compounded medication is right for the patient. And it's important to note the prescriber has to write for a compounded medication. The compounder can't write Wegovy or Mounjaro on the script.
It can't just write any name. Right.
And it gets to the pharmacy, and the pharmacist said, I don't have any of that, so I'll just compound it. It doesn't work that way. Has to be a compounded medication. And so the interesting thing about all of this is that, just by its very nature, compounded medications tend to be less expensive than commercially available drugs. And so a lot of the media has made a point of, a lot of people are going to compounders to get this semaglutide or tirzepatide because it's so much cheaper.
Purely as a cost loophole, right? Is kind of what some of that message is.
Yeah.
Yep.
But that's not really the reason compounders are doing it. I mean, compounded medications by nature are just cheaper. They don't have to go through all the regulatory crap and the marketing and the price increases that the PBMs bring into the drug supply. They don't have to do any of that.
Sure.
And so they're cheaper.
Yep.
And so I presume that has been the motivator for some patients. It's not necessarily the motivator for compounding pharmacies. Compounding pharmacies are trying to meet this need.
Yeah, I would say I think from what I'm hearing too is really it's what's driving all of that is just the overwhelming demand, right? And then the supply is not there. Once they get all that sorted out and they get those removed off the list, all of that's kind of done. It's kind of done. But the other thing that I would say too, to like, I agree with you, like in you're out here messaging, in my opinion, part of like, hey, look, this isn't hocus pocus, this isn't sketchy stuff. Right. And what I like to point to at times with some of that stuff too, to kind of like prove that point, is look at all the compounding you have to do for pediatric patients. And if that didn't exist, you know what I mean? Like how hard it would be to treat patients. Absolutely. If you couldn't dilute something down to something that a really small person, a child has to use. So like I always look at that as you're like, that's a proof point. Usually everybody can be like, oh, okay, that makes total sense, right? Like these medications aren't really built in mass at times for just children. So I always like to point to that piece too as well. So.
Yeah. Well, and the other thing, when you're talking about semaglutide and tirzepatide, you're talking about an injectable. This is sterile compounding. Yep. These are made
Not everybody's even doing that.
Qualified compounding labs. I'll tell you a story, and it's really interesting because I think this model has legs for us. There are a lot of well-intentioned people out there reporting on compounding who have never walked into a compounding pharmacy, who have never seen a compounding lab. Back in September, we had our Compounders on Capitol Hill event. It's our fly-in. Yep. And a Politico reporter contacted me during the fly-in, and she wanted to know about what we were working on, and we sort of struck up a conversation. And she's a national healthcare reporter for Politico, lovely person, is writing about compounding in FDA and had never been in a compounding pharmacy. So we invited her for an on-background tour of a sterile compounding lab in Arlington, one of our great members, Preston's, in Arlington, Virginia. And she spent an hour and 15 minutes or so. We allowed her to ask anything she wanted to ask. She asked about hazardous drugs. She asked about certainly semaglutide, tirzepatide. She asked about ketamine. She asked about these hangover clinics. And none of it was on the record. It was a learning opportunity for her. And she came away with a better understanding of pharmacy compounding, and I think a better appreciation of it. We had her garb up and scrub in so that she could go into the sterile lab. Certainly, we didn't allow her to do any actual compounding, but just that process, I think, was impressive. And that was so successful that about a month later, we invited 3 other reporters, one from Kaiser Health News, one from Stat News, and interestingly, one from the Wall Street Journal, into that same compounding pharmacy. And that 1-hour tour turned into a 2-hour tour just because of all their questions. And I guarantee you, they walked away with a better appreciation of the regulatory framework, the compliance, the care that compounders take. And APC, our board, as a result of that, has allocated some money for 2024 to do more of that, to get healthcare reporters around the country into compounding pharmacies. So, I'm not expecting every reporter to write a glowing story about pharmacy compounding, but I would expect them to be well informed about what they're talking about. And so that's sort of a strategy for us in 2024, related to mostly related to semaglutide, somewhat to ketamine. Ketamine's a different issue, but we're trying to educate reporters about what compounding is.
And that doesn't surprise me. Some of those are the things kind of making headlines too, and those are the things getting clicked for the stuff that they're asking about. And then you get in there and you actually experience a real compounding pharmacy that's actually a sterile compounding pharmacy, and you realize, this isn't a fly-by-night stand-up kind of thing. You're like, holy smokes. And just the amount of money and investment it takes to even get something like that started, you have to be full-blown serious for that. And really, you get in there and you realize, you tie that to the story of like, here's the patients we're helping. Yeah. And you just try to obviously you got to let it land how it lands. But really, that's what people don't quite get the whole picture of, especially in a community pharmacy or an independent pharmacy that's doing that kind of stuff. So totally agree. So I'll segue that into like what's teeing up for 2024 for you guys. I know you guys got a lot of initiatives. I know this is still kind of still front burner for you, the GLP-1 issue, and helping people through that. But what else do you kind of have teed up through 2024?
Well, strategic, we've kind of got 3 things. So I mentioned one strategy, which is beginning to educate media about pharmacy compounding. We are also working both in the Senate Health Committee and the House Energy and Commerce Committee to get into federal law that pathway that I mentioned for 503As to be able in rare circumstances when a hospital can't source a drug from the manufacturer or the 503B to allow the A to do that. And again, we're talking sterile drugs. Sure. We would like to see as a part of that maybe some enhancement of the FDA drug shortage list, or at least authorization for the agency to make those enhancements. And so that's part of our Capitol Hill strategy. One that we're working on pretty hard, and we're working to bring FDA along with us. Has to do with a memorandum of understanding that was authorized by Congress. Well, let's say this. I have a daughter who is an attorney in D.C. Okay. She's 27. This MOU was authorized by Congress just shortly before she was born, and it's never been implemented. FDA has gone through several iterations of an MOU. Congress actually instructed FDA to create a memorandum of understanding that it would enter into with each individual state that would provide, it would require compounders who ship more than 50% of their compounded medications across state lines to report that to the National Association of Boards of Pharmacy and FDA. It's gone through several iterations. We believe that FDA overreached because what Congress authorized was reporting on distributions of compounded medications. Okay. So we're talking about medications without a prescription. Right. And so that happened in 1997. 2013, we get DQSA and the creation of 503Bs that can do distributions. And along with that, we get guidance from FDA that says, okay, 503As can only dispense pursuant to a prescription. So now you've got an MOU that is about distributions, and only 503Bs can do those distributions. Right. And 503Bs are licensed now by FDA. They're not licensed by state boards of pharmacy. Right. It's by FDA. So we say the MOU is obsolete. Nevertheless, it has remained in federal law, and in FDA's defense, because it's in federal law, they've had to continue to work on it. Yeah. They finalized it in 2020. It was immediately the subject of a lawsuit by 7 compounding pharmacies. The court ruled in favor of the compounding pharmacies and found that FDA didn't follow the proper process. And so FDA is now back at the drawing board. That's what the court told it to do, creating an MOU. We are saying to FDA and to Congress, this is obsolete. Let's get it out of the law, and let's authorize in law, require in law, the kind of reporting you want from compounding pharmacies. We don't have a problem with if you ship more than 50% of your production out of state, that you would report that to FDA and to your state board of pharmacy. We think it's reasonable that they would want to know about that. And then the other thing, and frankly, it's a sweetener. FDA has long criticized traditional compounding because there's no adverse events reporting framework. Okay. And so the proposal that's coming together that we hope to introduce in Congress, and we hope with FDA's support, and I would say we're getting some good signals, although they've not committed yet, would be legislation to eliminate that MOU, to require reporting by pharmacies that ship more than 50% across state lines, and that would implement a mandatory adverse events reporting framework for 503A pharmacies, and it's only reporting of serious adverse events. FDA has a definition of what is serious. Right, and they have that. I don't think anybody can disagree with anything on the list. Yep. And so we don't want frivolous adverse events reported, but serious adverse events. And so we are hopeful that fairly soon that will be introduced in the form of legislation in this Congress. And we're hoping to move forward hand in hand with FDA on that. Wow. Okay, cool. Yeah, that sounds reasonable. What about at the state level? I know some. What are you seeing trend wise? Are you seeing anything pharmacies should look out for at all from a state level perspective, or just improvements in things as well? I know a few states are trying to do a better job of kind of enumerating what compounding capabilities pharmacy have. What are your thoughts there? What are you seeing? There are some minor issues that we work on. Savannah Cunningham, the pharmacist, Mercer grad, is our director of public policy, and we are growing, trying to grow our influence and credibility with state boards of pharmacy and state legislatures. So over the past year, we've been involved in 14 or 15 different issues with states, and they sort of run the gamut. Some of them are, pardon me, crazy. We had one state board of pharmacy that proposed a regulation that would require the name on the label of the prescription of every staff member in the pharmacy who handled that prescription. If I scanned it at the point of sale, I gotta. Well, and you've got your compounding log that includes all that. Yeah. And you already do that much real estate on that label. Yeah, you already do that today anyway. It's just not on the label. And what's the patient going to do with that information anyway? Right. Well, and what would a regulator? Why do they need it on the label? And so we were able to intercede there, and that quietly died. Sure. And so there are some like that, always well intentioned, but sure, not always rooted in. How does this help the patient? How does this keep the patient safer? And if you can't enunciate that in regard to any regulation related to compounding, I don't think it's good regulation. I guess the biggest issue that we're dealing with in the states right now has to do with the new USP chapters. So USP over the past several years has proposed and finalized new chapter 795. 795 deals with non-sterile compounding.
Right.
That's the standard, which most states adopt. 797, chapter 797, is about sterile compounding.
Right.
And again, most states adopt that. And more recently, USP 800, which has to do with hazardous drug compounding.
Right.
The interesting thing about USP 800, it is focused almost entirely on the pharmacy staff themselves and how you keep those staffers safe in the compounding lab when they are dealing with hazardous drugs. I would say USP 800 is controversial.
It
there
seems to
are
be.
some, there are some who love it. There are many who say it's unnecessary, it's overreach. And so we've got states that are trying to figure out what they do, both in terms of USP 795, 797, but also in terms of 800. Most states adopt 795 and 797 in total without question.
Yeah, usually pretty straightforward with those two, right?
Yeah. The problem, there is a problem we perceive with USP 797 in that the new chapters incorporate what we would call arbitrary batch sizes for sterile compounding labs, where in the past you could do a batch size of 1,000 and only go into the clean room once. Under the new chapters, that batch size is limited to 250. So that means that if you need 1,000 units, you're going to have to go into the clean room 4 times, increasing the likelihood of contamination, et cetera. Your cost of materials and all of that.
Yeah, your input costs go up. Yep. And
absolutely.
Your chance for something happening goes up too, the more.
So we're urging states to look hard at that. We would urge states not to adopt both batch size limits and some of the restrictions on beyond use dates in the new 797. USP 800 is a different matter. There are some state boards of pharmacy who are looking really hard at that and saying, do we really need to do that? Arizona is a good example. The Arizona Board of Pharmacy back in the spring indicated that it was going to adopt 795, 797, and USP 800, and then in the fall of last year rescinded that decision, appointed a work group, and decided they were going to look a little harder at those chapters. I know I live in Alabama, War Eagle. You probably see it on my
We all do.
Yeah, right. But the Alabama Board of Pharmacy, there is a group of compounders that are urging the board not to adopt USP 800 at all. And some of the argument here, and we think it's a wrong-headed argument, but there are attorneys general and their staffs that would argue that the Food, Drug, and Cosmetic Act requires incorporation of USP chapters in state law. And that's a misreading of the Food, Drug, and Cosmetic Act. The section of the Food, Drug, and Cosmetic Act, and not to be too arcane here, but
you're good.
It's important to this discussion. The Food, Drug, and Cosmetic Act says that the API that compounders use must be USP compliant. It doesn't say that the compounding labs have to be, or that the standards that the states adopt have to be. And so we believe that's a misreading of the Food, Drug, and Cosmetic Act. And we've written to state boards of pharmacy to say so. We're still getting a bit of pushback from some of those who disagree with us, but the plain reading of the statute, I think, makes that clear. That USP 800, 797, and 795 are big issues in states.
Kind of your more local fights / conversations you guys are having all the time then.
Yeah. Well, and part of the deal related to that is when they're going to start enforcement. I mean, USP says that they are, the word they use is compendial, but that means they're enforceable as of last November 1st. A lot of states are delaying that. And so if I'm a compounder and I'm licensed in 14 states, I've got 14 states that are all doing this differently. And Louisiana may say that I'm going to implement come November 2024, and Mississippi says, no, we're doing it in May of 2024, and you got another state that hadn't decided yet. So there's a lot of compliance that pharmacies are having to stay on top of as states wrap their heads around what they're going to do with these new USP chapters.
Yeah, that makes sense. It kind of makes you go, hey, do you just kind of comply to the lowest common denominator, whatever's the most strictest one, and you just keep your pulse on the rest, and you go forward with that, even though that just constrains you even more. But That makes total sense. Okay, so I will shift gears just a smidge, a little bit, since we probably only have like about 10, 15 minutes left in this. One other quick hit I wanted to try to get from you on your perspective on things is like on the business side of the house, especially for the 503As. I'll say the dispensers. I'll say that for the group.
Yeah.
What are you seeing trends there? Are you seeing like, hey, look, more and more of this is moving cash, less of this is moving out of pharmacy benefits? I think that's been the trend. Obviously I'm not breaking any news there. Is there anything that's noteworthy on the business side of the house for any of these pharmacies that are thinking about it, especially going into 2024, or anything that you could share there?
Well, purely anecdotal. I've heard it. I've heard it multiple times, but nobody's done any research on this that I'm aware of. I am hearing that there are traditional independent pharmacies that are looking to compounding because it can be cash only. They don't have to deal with the PPMs, and they're contemplating a move to be compounding only.
We have some pharmacies that are Pioneer customers that are just straight up, they may have multiple pharmacies, but one of them is just a compounding pharmacy, and it's just a different cost structure to them too, as well, to keep it segregated from a business perspective. So yeah,
absolutely. And I mentioned Preston's. I hope I'm not giving away any business secrets, but when he was when Scott Welch, the pharmacist in charge there, was doing this tour for these reporters, he indicated that he's a hybrid pharmacy, so he's doing traditional retail and he's doing compounding. And he just flat told the reporters, I lose money on 90% of what I dispense on the traditional retail side, and so compounding supports. Compounding is how he's continuing to remain in business. So that is a trend I'm seeing, and I would make an argument. There are a lot of traditional retail pharmacies that do a small amount of compounding. It's typically non-sterile compounding. We tend to think that if you're doing 10% or more compounding, you certainly ought to be a member of our organization because we're representing your interest. There are pharmacies that do less than that, and maybe it's just flavoring occasionally, or they get five or 10 compounded scripts a week. Do they need to belong to the trade association? I would suggest to you that the potential for a small pharmacy to do something wrong because they're non-compliant and they didn't know about the regulation is pretty high. And so I would make an argument that if you're doing any level of compounding, you ought to be a member of our organization so that we can help you stay compliant.
Yeah, so, you'll have a nice CE course for that too. If you think through, like if you're wading into those waters, anyone listening that's going like, hey, I want to add to or diversify a little bit in the patients I can serve from that perspective, and you want to add compounding to the profile of your business. Yeah, you guys have a lot of, I think, CE towards making sure you're doing the all. I'll just say as compliant as possible with some standard operating procedures that make sense.
Well, and let me a quick commercial, 15 seconds. In partnership with the College of Pharmacy, School of Pharmacy at Virginia Commonwealth University, we've developed a 15-hour compounding curriculum. It is entry-level foundation for new technicians, new pharmacists, and it's everything you need to know about the ethical, legal, and regulatory framework of compounding. It's one thing to know how to compound a preparation.
Sure.
It's another thing to know about the compliance and the laws and why you do what you do. And so that's what this course is about. You can find information on our website. The other trend, you mentioned trends. The other thing that I'm seeing is some consolidation of compounding pharmacies. There are private equity companies that are getting into the business of compounding pharmacies. Some of those are in conjunction with telehealth platforms. We have a company like an APC pharmacy facility member, Revelation Pharma, that is buying up. It's like a holding company for pharmacies, and Revelation is allowing those pharmacies to retain their identity in the community as, this is who we are, we're this kind of pharmacy.
Sure.
But they're also providing some standardization of processes and compliance, et cetera. And so they've grown from a couple of 3 pharmacies 2 years ago to, I think it's 13 or 14 pharmacies. We're seeing Belmar, which has purchased Women's International and some other pharmacies. We've seen private equity, Empower out of Houston, has had an infusion of cash from private equity, and they're able to build a beautiful state-of-the-art facility there that's working with a lot of telehealth platforms, et cetera. So that's something that I'm seeing as well.
That's true. I didn't even think about them being in the segment we've been talking about as like I'll just say your larger scale, the stuff you see on commercials and TVs and things like that around segments around like hair growth and ED, and even now I think they're wading into GLP-1s and things like that.
GLP-1s, yeah, absolutely.
I didn't even totally even forgot that they're even part of this segment as well when it comes to compounding, because some of that stuff they're just manufacturing or contracting out to manufacture, I think, from what I understand, some of their own compounded formulas for some of that stuff, especially with treating hair and things like that. For that. So yeah, that makes total sense. Well,
and I will tell you, I'll just name names. I mean, we were delighted last year that Hims and Hers, which you see commercials on television, they are APC members. On the veterinary side, we hadn't talked veterinary, but that's the
whole
big
other
deal.
animal. Pun intended.
Yeah, Chewy is a member of APC. So I think it's gratifying that they are seeing value in belonging to our trade association. They perceive that we are representing their interests, and I hope to heck we are.
Well, good stuff. The other thing I'll say for current members, I'm sure some of those are listening today. You guys have I think something that's called APC Fellows that I wanted to plug for you. Which is really, I don't know if is that voting or that submitting all wrapped up done. Is it done yet or not?
Well, we do it annually. Okay. The applications will be open in March for the 2024 class of fellows. And then they will be installed at our Compounders on Capitol Hill event this September in Washington, D.C. And it's a fellows program like NCPA and APHA and other groups have. But it really signifies a high commitment to professionalism and ethics and
service to the industry.
We're proud of our fellows, yeah.
Yeah. So that's going on. You could submit people for that too, and pharmacy techs too, from what I understand.
Absolutely, yeah. And year before last was the first year that pharmacy technicians, compounding pharmacy technicians, could be installed, and we did install several of them. It's a good program for technicians.
Scott, y'all doing a bunch of work. Real quick before we go, I like to hit on personal stuff. And what I mean by that is let the group get to know you a little bit. Yeah, I know you're in Alabama. Kids, how'd you get into pharmacy? How did all this how did we get Scott Brunner that we have today? Like how did we do that? What compound did we formulate to get this?
Right. It's a complicated formula. No, I've been an association guy practically my entire career. I graduated with a degree in finance, minor in English. Went to a little liberal arts school here in Alabama. And went to work for a bank, and I was a square peg in a round hole. So stayed there for a couple of years and just fell into an association job doing association communications for a realtor association. Okay. And I worked in the realtor organization for about 20 years in Mississippi and Virginia. And in 2014, responded to an ad looking for something different, and was hired by the Georgia Pharmacy Association. Okay. And have been doing pharmacy ever since. And I think our members, not to get sappy
we do sappy here. We do sappy.
Yeah. Well, our members are doing the Lord's work, if you don't mind me putting it that way. They are really changing the lives of folks for whom traditional medicines don't always work. Yeah. And so it's easy to come to work each day because I'm really proud of our members. I do think we have work to do in compounding and maintaining the ethical standard and our APC Code of Ethics. I mean, in order to belong to our organization, you have to subscribe, we say, to the Code of Ethics and indicate that you're going to live by that. And we're doing everything we can to promote that. Some of this work I've talked about with media is about that. But anyway, our office is in Alexandria, Virginia. We rent a little bit of space from the National Community Pharmacy Association up there. And we're a remote organization. There are 7 of us. We're about to add 2 new staffers, so there'll be 9 of us. And we're all remote.
Growing by 30%.
Yeah, absolutely, and much needed. But anyway, I moved because we're remote. I moved to Auburn about 6 months ago. My wife went to school here, and we're Alabama folks, so we're loving smaller town life now.
A little smaller town, especially from basic. Yes, from where you're at too.
Yeah.
That's cool. Last thing, I like to try to like ping people on if they can give me something or not. A little section called Prescribables. I'm coining it. What are you reading, listening, or watching right now? You think the rest of the group could, and it doesn't have to be work related. It could be fun too.
Well, I'm an avid reader. Tend to read fiction. My wife's the nonfiction reader.
Okay.
I read fiction, and so I'm reading a book called The Wind-Up Girl right now. It's science fiction and it's creepy and dark, and I'm not sure I like it. But we're
at least you're willing to stay with it. The second I feel like I don't sure I like it, I'm out usually.
Yeah, we're going with it. I tell you, I've been thinking about putting together like a 15-minute video for our members that I want to call my routine.
Okay.
Just so I'm thinking that some of the online tools that I use might be helpful. But as a part of that, I subscribe to one of these RSS things. I use NewsBlur. Had it for years. I love it. But I read the Washington Post, the New York Times. I scan the Wall Street Journal.
Yeah,
in terms of healthcare reporting, I'm a big fan of Stat News. They have a feed that you can get some of their stuff without having to have a subscription. We do have a subscription, and it's good. Axios Health is a daily morning consult. Health is something that I read, and it's how I stay current. I think my board may occasionally grow tired of me sending them, texting and emailing them little stories that I see in Stat and Axios, but that's really how I stay current. NCPA has its QAM newsletter that I certainly watch. But those are the basics. If that can be helpful to others, I do think they're quick reads.
Yeah.
And so for what it's worth.
For sure. Well, Scott, man, you were great to have on. I appreciate you being on. Appreciate the work you and ACP are doing as well. And man, just have a great rest of the week. Keep fighting the fight. Pharmacy loves people who will fight for them. It seems like you guys are doing that in spades. So.
Well, thank you so much. I appreciate the opportunity to maybe talk your ear off. Thanks.
You're good. All right. We'll see you, man.
All right. Take care.
All right. Bye, everybody.
Thank you for watching the Catalyst Pharmacy Podcast.
If you enjoyed today's episode,
please like, subscribe, and follow us wherever you get your podcast.
give us a 5-star rating on Apple Podcasts to help us reach more pharmacy professionals like you.